right, good morning, everybody. Good morning. Hopefully you can hear me okay. So my name is Hales, and sorry to disrupt the ice breaking. There'll be lots of time to chat with folks as we move throughout the day. So I'm a cognitive neurologist at Emory, and I was given this interesting title this morning, which I'm not sure that it's all that well organized, but we'll see where it takes us. And so if we start with the title, it's, well, is the ground changing for practice as we move forward, or are we trying to change how PCPs do things, right, depending on how you read that? So just kind of keep that in mind. That really the main purpose for this discussion today is just to get us all to thinking about the different issues that you're actually going to hear about throughout the rest of the morning, the afternoon, and into tomorrow. And hopefully, try to think of solutions, because I want to be the first to tell you, we do not have this figured out yet. And so we do need some help with that. And I'm going to need your participation this morning. So hopefully you've had enough coffee. So we're going to start with provider perceptions of best practice. And all I'm going to need from you guys is just to shout out something. It could be a word, it could be a phrase, it could... you could just answer the question that I'm gonna ask. Just kind of the first thing that popped into your mind. I don't want you to think too much about this because hopefully it'll work. And you don't have to limit it to cognition. I want you to frame this in your other practice, because you're not just seeing people with memory disorders, right? You're seeing people with hypertension and diabetes and everything else that everybody has. Preventive maintenance. So perception. So if I just flash 78-year-old, first time coming to see you, what do you think about? Osteoarthritis, great. Falls, yeah. Forgetful. What was back here? Frailty. What if I add in that they're a woman? What are you going to recommend, or what are you going to do? What else, how does that change your perception of that patient? Bone density. Excellent. What else? Urinary incontinence. We're hitting big ones. I'm not a PCP, but I know that those are pretty big ones. What if I change it to a man? BPH. Okay, yeah, so we're great. We're thinking about different things here. So how about we throw in that you've gone through all the other stuff and they don't have a cognitive complaint, but they're 78. Do you think anything about cognition? Or do you just kind of move on to the other stuff? What's that?
Functional level.
Functional level, okay. They don't have a cognitive complaint, but maybe thinking about, well, how are they functionally? What else?
Are they living alone?
Okay. Are they living alone? Maybe they came by themselves, or maybe they do live alone, right?
Alcohol use.
Alcohol use. Getting ahead of me here, but yeah, good. Very important to think about. So let's change it a little bit. Now we got their 78-year-old. Now they do have a mild cognitive complaint. What do you do? What are you thinking when they say, doc, I feel like I just can't remember very well. I just can't remember conversations, or that I sent that email yesterday. It's all short term. What should I do? What do you think? What pops into your mind? What do you think?
Functional level.
Family discussion. Functional level again. Okay. Depression. Excellent.
How did you get here today?
Okay, exactly. Okay. Kind of jesting a little bit, but true, right? Navigation. Okay. What are you thinking about as far as workup is concerned, or are you? Labs. What was that? Mini-cog. Okay. Medications. Or do you just say, that's normal aging? How many people say that? That's what the patient says. Right. Okay. This is very important. Patient and family. Normal aging. We'll come back to that. What if it's more moderate or severe? Now what do you do? Calling the daughter. Dr. Law can make his joke later. If you don't have a daughter, you're screwed. Yeah, good point. So functional, coming back to the functional concept, there's a lot of stuff, right, when they're coming in with lots more complaints, and then that changes, right? Somebody beat me to it. If they have somebody that comes with them for any of these, no cognitive complaint, mild cognitive complaint, or severe cognitive complaint, that changes your calculus, right? Because now you've got an informant, and your perception of what may be going on kind of changes. We kind of alluded to this a little bit earlier, but when their 78-year-old comes in, plus minus cognitive complaint, what about comorbidities? And some people have already mentioned a couple of those. Medications I heard in the back, alcohol, what else? What other things do you start to think about if you're seeing cognitive issues and kind of trying to march down the road of, well, do I try to sort this out or not? What else could be contributing? Oh, that was a lot of things at once. Stroke. Okay, so stroke, vascular type stuff. What else? Depression, we heard that over here. Hearing impairment. Excellent. What else? Nutrition deficiency. You guys are pretty good. You don't even need us anymore. I mean, this is excellent. But yeah, there's lots of things, right? Vascular risk factors. Somebody said stroke, but we're thinking about hypertension, cholesterol, diabetes. Throw in lifestyle modifications. I mean, thinking about exercise, dietary changes, all that kind of impacts cardio, cerebrovasculature. We've heard depression several times. It's great that's really on your radar as a contributor. Sleep. Nobody mentioned sleep. Maybe you did. I didn't hear it. But sleep apnea. Right? We know that's there. We've heard about medications in the back. And this could be lots of things, right? It can be neurotropic meds, or it can be polypharmacy or other meds that have off-target effects. Some of the bladder agents. It's pretty common. What about if they're on anticoagulation? Where does that weigh into your thought process for any of this? Or does it? Fall risk, yeah. What about if they have a memory complaint? Falls aside, the concept of anticoagulation. Does that impact your decision making with ordering tests? Not really, and I'll come back to this point in a bit, but keep that on your radar as we're thinking about, well, how do we kind of refine how we see patients and decide which buckets should these patients go into for downstream therapies? And you'll hear more about that this afternoon as well. Other things we didn't really talk too much about, you heard about substance use, heard alcohol earlier. Family history, how much does that weigh into this for any of you guys? Do you ask? Do you ask about dementia or Alzheimer's or other things in family history? So yeah, that does occasionally come up. Now, let's change the perception a tiny bit. Let's go back over to our age. Now, what if they're 56? What did that just shift for you as you're thinking about, I don't want to go through all these again, but as you're thinking about these, either on the PCP side or memory care side, what changed in your mind when I dropped that age by 20 years? Or did it? Family history, lifestyle, sleep apnea, alcohol, endocrine, okay, interesting, FTD, chemical exposures, a lot more pressure to keep them functional. Do you associate, if they're younger, do you associate it with other underlying medical conditions or lifestyle things? Especially, let's say this is a woman in their early 50s and they come in with memory problems. What do you tell them? Or what are they asking you is this related to? Menopause. But is it? I mean, I don't know. I'm opening it up. But do you guys think that's a thing? And do you agree with them and say, yeah, it's probably menopause? It's okay if you do. I'm just trying to kind of throw that out as we're thinking about these perceptions. So that's more of the framed of the patient. What about perceptions of diagnostics? So let's take a little step into this a little further. Mammogram. First thing that comes to your mind. Helpful, not helpful? Do you order them? Everybody orders them in here? Well, I mean, I know Dr. Law doesn't, but okay. Why are they helpful? Give you a diagnosis. Who orders these? Sometimes. Okay. Are they helpful? Are they recommended? Yeah. Usually can save people's lives with these, right? How about this one? I don't know what to do with this one. Somebody tell me what you do with this. Yeah, somebody speak up. I know there's differing opinions. Who recommends this currently? Okay. And then how do you frame that discussion with your patient?
Age 50 plus, test for prostate cancer yearly in men over 50.
Okay, age 50 plus, I heard high risk. I heard patient asks for it.
It's not diagnostic of anything.
Right. Okay. How about on the flip side? Anybody think, based on some of the previous recommendations and also concerns about side effects of downstream therapies for this, about saying, you know, it might change management, but it might not be a good thing to change the management. Just kind of keep that one in the back of your mind. I'm glad somebody already hit this earlier. Hearing, audiology testing. Who orders that? Always. Excellent. This is perfect, right? I mean, this is something that, I don't know if Dr. Law is going to show a slide for this later, but it's one of the things in that Lancet report, fixing hearing later in life, that can kind of prevent dementia as you move forward. It's one of those correlations. So keeping it on your radar. And this is not all-inclusive. This is just to, and you guys have already beat me to the depression, but do you use some type of screening tool for the depression? And if so, what do you use? Or do you just rely on the patient to say, yeah, I'm just not feeling well, or you notice they're losing weight or withdrawn or whatever? PHQ-9, okay, great. What else? Any others? How about for depression, though, specifically? Yeah? Okay. Okay, yeah. And I got cognitive screening up there. That was my fault. I started to conflate the depression screening. But yeah, so for cognitive screening, yeah, we've started drifted it over. So we've heard PHQ-9, cognitive screening. We're thinking about labs, mini-cog. What else? Clocks, yeah. Anybody use MoCA, MMSE? MoCA. Have you done your certification training? Yeah? Certification training. Are you paying the guys who wrote the MMSE $1 every time you use it? MRI brain. So I put this one here. So be honest with me here. Do you think it's helpful? Patients want it. Patients want it. What else? The daughter wants it. Okay. Do you find it helpful, though? When you get that radiology report back, do you know what to do with that when you see the words there? Or do you just say, oh, says it's normal, MR is normal?
Sometimes it can be very brief.
Yeah.
Report, and then you have to dig in for the, like, look at the
Yeah.
pictures, and I don't know what I'm doing sometimes.
Okay.
I try my best.
That's helpful, yeah.
The radiologist, if he's trained in reading it for this purpose, then you get your answers much better.
But yeah, so very good point. Who is reading that scan? And of course, you guys see this. We see it all the time. Scan's normal. Patient's told the scan is normal from 2 years ago. I look at the scan. They've got profound right temporal atrophy. The temporal lobe's gone. Scan's normal. Patient was reassured 2 years ago that nothing's wrong. Right? So something's a little broken there. And you also brought up a good point about the reports in that very brief summary, but if you actually dive up into the verbiage, sometimes they put important stuff up there that by the time they got to the summary, they forgot to mention it. They're like, oh yeah, we've got vascular malformation, or we've got multiple microhemorrhages down at the bottom. Yeah, normal scan. So yeah, it's, we find it on our side to be quite helpful in some cases. Certainly it's not exclusionary if you don't see something present. But if you do see something, it can be helpful in the etiology. But to the point made up here, sometimes that requires a little bit of expertise, because you need to look at those images and put that in context with what you think is going on with a patient. All right, here comes the big one. Perceptions. What do we think about this? Who orders it? Anybody ordered it? Yeah, we got a couple folks. I want the GMN people to keep their hands down. Anybody ordered one of these, an amyloid PET scan, a blood test, okay. How about one of the A-beta ratios in the blood? Have any of the pharma people or any of the lab people gotten to you yet? So we are seeing this. Yes. How about your patients? Are they asking for these yet? They're reading about insurance. Okay, great. These are great. So they're reading about it, maybe asking for it, worrying about insurance coverage because at times maybe not covered, and some are expensive. One of the assays that's commercially marketed now, it's like $1,200. But in general, you're not ordering these from your practices, at least at this point. Do you think they're helpful? Like, do they show you that someone has Alzheimer's disease based on what you've heard, what you've read? Do you have confidence in them? It's a great question. So up here in the front, I asked about ApoE, right? You know, ApoE, of course, Jim might chat a little bit about that, but it's a gene, right? And if you have E4, you have an increased risk for AD, but doesn't confirm AD. But we're ordering it more now because it helps us inform our risk-benefit discussions for patients going on some of the newer therapies. So you've got two different things with the ApoE gene. One is risk factor, which we don't really think is that useful. And then the other, which is really useful, is predicting potential risk on these newer medications. And you'll hear a little bit more about that. All right, the fun part, interventions. Anastrozole. Who prescribes this? Has anybody written a prescription for anastrozole? In the back, I see one. Not for dementia. Well, I said this is not just dementia. Anybody know what this is? Anybody have patients on this? Yeah, of course. Yeah, everybody, right? Yeah, these people. Yeah, this is for breast cancer. Right? Does this cure their breast cancer? What does it do? In general, what does it do? Suppresses things a little bit, right? Kind of keeps, if there's some cancer cells sticking around that have that characteristic, keeps them at bay, so maybe the patient lives longer, right? Insulin. Helpful? You write, lots of people write for it, right? Is it dangerous? Why? Hypoglycemia. Can patients die? Do patients die from taking insulin? Yes, all the time. Anticoagulants. You prescribe for this, right? What do you tell your patients when you're first putting them on it? Do you tell them, what type of risks do you chat with them about? Bleeding, fall risk. How graphic do you get with that? No, I'm for real. Pretty graphic. So do you tell them, you could die if you take this medication, if you fall? But you prescribe this all the time, right? Is that a good thing? I mean, I know from my perspective the risk. I mean, my grandmother, sharp as a tack, 91, on Coumadin, died of a spontaneous intracerebral hemorrhage, right? They're bad, or they can be bad, but they also can be good, preventing these massive strokes in lots of people. Antidepressants. I know you all prescribe these. Are they helpful? Yeah, okay. What do you tell your patients when you put them on it? Anything? Do you tell them they may kill themselves? No, I'm for real. There's black box warnings on SSRIs. Do you tell every patient that you put on this that there's a risk of suicide? I see yes and no being shaken. So, for the record, it's tough. It is tough for every patient. There's a lot of things going on in a visit, right? And they're short visits. How in the world can you get to everything? Hearing aids, yeah, pretty helpful. We've already talked about hearing. Antipsychotics. Who writes for these? Oh, yeah, okay. I knew I'd get you on that one. What do you tell your patients when you put them on it? Or what do you tell the patients' families? Risk of death. Yeah, black box warning. Do you tell it? Same with the antidepressants, right? It's a black box warning. Increases risk of mortality. Do you think they're helpful for the patient? Sometimes, let's see, maybe, Are you often trying to treat the patient's family more than the patient? Does that come up? Yeah. Trying to keep them at home, yeah. So there's a lot of things floating around with the antipsychotics, right? Acetylcholinesterase inhibitors, I know you're right for these. Yeah? Who's not comfortable writing for donepezil, rivastigmine, galantamine? Okay, so I'll assume that everybody's comfortable. What do you tell your patients? Okay, well, you're the expert, not you. Well, who else? What's that? I apologize. Can't hear. They don't help. Interesting. What else? Any other opinions? What do you tell them? What, exactly. Okay, we're getting at side effects. Yeah, appetite, weight loss. Don't help. Somebody needs to step up for donepezil or rivastigmine here. I'm getting some beef on it back here. Diarrhea. Oh, we're still going down. What else? Anybody think this is helpful, or what do you tell them? What do you tell the patient when you put them on it? Yeah, go ahead. Okay, that's another hand back here. Slow progression. Finally, somebody said slow progression. Okay, great. Okay. Yeah. So actually, very good point here. That it can be helpful sometimes, particularly in patients that might have some psychotic-based features, some behavioral features, particularly if you're thinking more along the lines of dementia with Lewy bodies, may be a little more helpful. So that's why I wanted to keep pushing on this, because in some cases, it may be helpful. Right? I don't know. How about memantine? Anybody prescribe that? Do you say anything differently with that? How far along does your patient need to be in the cognitive decline process for memantine to be prescribed? Moderate to severe. Okay, so people that are experts are answering those questions. Okay, but yes, so how often do you put patients on this because the patient says, I got to have something, doc. Put me on anything. Do you put them on it, even if their MoCA is like a 26 and they say they have memory problems? And so perceptions, as we're thinking about, was it helpful? Well, I don't really know. It wasn't really tested in that patient population. Maybe a little bit less clear. All right. First of all, who has access to social work? So some, okay. How often do you recommend that for your patients? I see some kind of mixed in. You'll hear more about this as we move through the day as well, but thinking about non-pharmacological, right? Environmental changes, resources to support family, things to help keep them in the home that may be non-pharmacological, being helpful. And of course, the big one, that you'll hear more about later, perceptions on these. And I'd like to spend just a couple minutes here. What do you guys think about this new class of Alzheimer's medications? Pick the right population. Refer to the neurologist. Okay, we'll talk about that in a moment. What else? Risky. Excellent. What else? Expensive. Yeah. Potentially burdensome. Man, you guys have done your research. Yeah. Thinking about quality of life, going to an infusion center every however many times, different MRIs. Thoughts on whether it's helpful? Or and it's okay to say you don't know enough yet to know whether it's helpful, but I know you've got thoughts on this. Go ahead, right here. Disease modifying. We know it removes amyloid. Okay. What about clinical outcomes? I heard a Anything else other than a Okay. Okay, benefits worth the risk. Small improvement for that amount of investment, whether it be risk, quality of life. Okay.
But that's a start, so we need to keep that.
Okay, good. Who planted this person down here? She said you got to start somewhere, right? And so that is a good point. It doesn't negate some of the other things that have been discussed, and Jim will chat a little bit more about this later, but just trying to get you to think about some of these. So a couple of comments. We've talked about some perceptions. I tried to go into the literature and see what other studies have people looked at, trying to understand how PCPs view their role. And the perspectives for the role of that primary care provider, it's impressive, right? Your ability to potentially get people plugged in as first point of contact. You have trusting longitudinal relationships with patients. You've got the whole patient. You're thinking more holistically about the patient. That there are substantial opportunities when you think about those diagnostics and interventions and putting it in context with all the other things. And then, of course, the concept of prevention as well. You're already talking with them about preventing heart disease. And, tack on some brain health stuff, right? But there's the big elephant in the room, right, is this issue, right? This was one of the comments in this particular study, which, who else is better suited to try to manage and kind of tackle all of this? But you can see there, you don't have the resources, right? You don't necessarily have even the systemic level support to do some of this. And I looked at other countries. I found a study in Saudi Arabia. I found this one in Germany. I thought this one was pretty good. They surveyed like 2,000 people, and they were like, well, what's the perception of managing these patients? And I want to be careful. This mentions dementia, but I don't want you to conflate dementia with the spectrum of patients who have cognitive impairments. Okay, and I'll mention that briefly at the end, but just replace dementia in your mind with kind of cognitive impairments, right? That's managing patients that have some level of cognitive dysfunction. And you can see the top 4 here. Little financial incentive. This one I thought was really interesting, and somebody kind of alluded to this earlier. But to many patients, diagnosing dementia is an affront to their ability to make decisions independently. I'm extremely reluctant to do this as this restricts patient care. How often does that come into the back of your mind when you're chatting with the patient about those symptoms? And, well, is that going to impact their ability to get to the grocery store if I tell them they can't drive? Right? Or, yeah, go ahead.
Just getting back to the treatment thing, are there any really good scientific studies with dietary changes like keto?
It's a good question. I'm going to table the question about keto diet till a little bit later, but it's a good question. We'll come back, I won't come back to that, but you might hear a little bit about other interventions as we move forward. One more time? Yeah. The third point, this one often comes up. Nobody has said this yet because I haven't asked you outright, but how many folks even tell their patients this in the discussion? When they say, I've got some mild memory problems, doc, what should I do? What's going through is this going through your mind? Well, there's not a whole lot that we can do yet. Do we really need to look any further? And then this has also come up. Send them to the neurologist, right? Yeah, you guys are right in line with this German population. And then, of course, then on the flip side, there's these other issues, right? Access. How often do these difficulties arise? Booked. Don't have the time to discuss. And, of course, these are some things that I think you'll get into a little bit in the third session, a little bit later as well. And, just this whole kind of systemic issue. We were chatting about it at the table back here this morning. It's just tough to get people. The process is broken with that referral. And, of course, you'll hear a little bit more about Georgia MemoryNet as we go through the weekend. Again, we haven't solved it. We still don't have probably the infrastructure to manage the need, but we're making a start. And so why is all this important? You got these kind of perceptions we've talked about. You've got the challenges. Well, when you look at the modeling, if you just look at the Alzheimer's disease-modifying therapies, and even though this is for disease-modifying therapies, I do want you to kind of take a step back and think about this more broadly as we're just taking care of this patient population. That when you look at modeling, it's the wait times and the ability to see patients and get diagnoses is not great, right? And so just to orient you to this, It goes the year 2025 to 2040. And let's focus on these upper two graphs. They're basically similar. And it says, well, what if we took some of our processes diagnostically, and et cetera, and more PCPs did them? And basically what this shows is that whether you have low PCP uptake of that or high PCP uptake, which means they're just doing everything, that again, the rate limiting step here is still the specialist, which was already brought up. Right? The specialist visit for the treatments or the diagnostics. In this particular case, those orange bars represent PET scans. We're hoping eventually they're going to go away and we'll have better tools. But you know, it doesn't fix things to just say, okay, you guys do all the workup now, and then let's see where that separates it out. Let's change the calculus a tiny bit, though. Let's say we start using blood-based biomarkers in the PCP setting. What does that do? Well, the wait times are still not great. You've still got 2 years and a bit, but you cut the rest of it by almost half if you start transitioning some of these blood-based biomarkers into the primary care setting to help clarify diagnostics, because the goal is to identify those patients that might be ready for those other downstream therapies and hopefully try to weed out those who are not. And I like this graph because it highlights the opportunities. So let's say, just to orient you, your average wait time in months going from 0 to 70, and the number of treated patients with MCI due to AD in millions. If there were no constraints on the system, then we'd be able to treat the 5 million people that need to be treated like that. It's like a Thanos move, right? For those who know Marvel. But the issue with that is, there's a lot that goes into it, right? It's not just specialists. It's not just primary care. There's MRI infrastructure. There's drug manufacturing. I mean, there's a lot of stuff that goes into it. But no constraints, this is where we would be. But even if you do the blood biomarker piece, you're still going to have some wait, but you increase the number of people who are being treated. And then this is that low and high uptake of PCPs doing some of the workup, showing that if you have high uptake, all that's going to do is just create more backlog. Right? And so from our standpoint, as we're thinking about models, how do we try to address that? And again, I don't have the answers. This is just kind of putting some food out there for you guys to chew on a little bit as we're going through the weekend and continue to ponder it. So we can't talk about perceptions unless we come back to the patient. And we've already alluded to some of this, but what are the patient perceptions of best practice? What are they expecting when they come in? And we're not going to go extensive on this, but what if they have no cognitive complaint? And we're going to narrow it to their brain health. What's their perception of care from you as the PCP if they have zero cognitive complaint? What do they expect you to say about their brain health? The answer may be nothing. But do you think about this? Like when you have patients, no cognitive complaint. Well, let's say you've got your 65-year-old coming in for their annual wellness visit, and you ask them the questions, do they have memory problems? They say no. Do you leave it at that? What about if we change it? Mild cognitive complaint. Now what? What's the patient's perception that you're going to do from them? And go ahead. Get them better. Reassure them. How so? Normal part of aging. Great. So reassure them. What else? And somebody brought this up earlier. Patients are asking for that MRI or saying, I've got these memory problems. Order something to figure this out. What else? Prescribe something. Yeah. We're in a, give me a pill. And that, oh, wow, okay. That's really important. The pill will take them back to baseline. And this is getting into not perceptions, but expectations, which we're not really going to talk too much about today because I don't have more than like 5 minutes left. But expectations. What are the expectations that we as the provider and the patient, how do we kind of talk about that? Is what we might anticipate with that donepezil or amyloid monoclonal. And of course, the patient perception with moderate to severe, it's tough, right? They might not even know who they are. Or They may, or they may feel like they have some problems and just not know what to do. What do you guys think when you have somebody who's in that kind of moderate to severe dementia? How do you approach them? Do you say, oh, this is going to be an easy visit. I can hop in and out in 5 minutes. They're not going to say much.
Also find that they're fearful that you're going to take their
Oh, yes, absolutely. So that independence thing, of course, here it's driving, right? Unfortunate, yeah?
Going back to Mal, I'm having more patients bring in a picture of Prevagen or
Oh, yeah. Yeah, we won't get into that too much. But yeah, so a multivitamin is fine, but above and beyond that, spend your money on Mediterranean diet and an exercise routine. So, and then of course, what are the perceptions of the family?
Get me a daily caregiver.
Daily caregiver. They want help. They want help. And not, yeah, I heard this, and round the clock. They don't want just 2 hours a day to come help bathing. They want round the clock. And so, what to expect? Also really important. How are we going to allow or enable patients' families to help care for them if they don't really know what that road is going to look like? Is it?
I think they feel like we're the referee.
Interesting. Yeah, so sometimes it does cause a problem with creating some conflict between caregivers and patients, especially when there's that family dynamic of, well, that patient has always been in charge and nothing else is going to satisfy, right? That definitely comes up. So how do we, last couple minutes here, how do we shift your perceptions about some of this, whether it be related to diagnostics or interventions? Okay. Data. Show me the money. What else? Yeah. And I'm almost out of time, so I'll show you what I thought about, and it's in line with what you guys are thinking about, right? And this is not all inclusive, but there's lots of things that we can do, I think, to help with that. And of course, somebody said data. You'll see I added one for you here, demonstrate value and benefit, right? To show you that this is helpful. How do we shift patient perceptions? I almost left this one blank. Honest and upfront in the beginning. Okay. Education. TV ads. Oh, yes, destigmatize. You guys are pretty good. I didn't leave it entirely blank, but I did come up with a few things here that I think in line. Do we pay people? I think we could do a better job if we actually paid people to do some of these things. Make it straightforward. You get your numbers to this or whatever, you'll get X amount. But at the same time, that's also hard because you're changing behavior. I know I have a hard time. At Emory, we have our insurance plan. You can go in and sign up for some incentive if you fill out some questionnaires or track stuff over a period of time. I don't have time for that. Probably give away several $100s a year because I just can't fit it in. And so even that has its issues. So you got to put this in context, right? This is going to be tough to solve, but you have to put this in context with the spectrum, and we'll focus on Alzheimer's, but it could be FTD, it could be DLB, et cetera, but Alzheimer's is the most common. You're going to put this in context with, well, Alzheimer's disease is something that starts with normal cognition all the way through dementia, and you've got several decades of things changing in the brain and deciding, well, when in this curve do you intervene and try to make something happen for that patient? But to do that, you got to know that it's there, right? And so when do we start to shift from being reactive to proactive and being preventive? Some of the trials now, they're on this curve somewhere. They're identifying people that have amyloid in their brain but no symptoms and trying to say, well, can we improve that? So what's going to happen to your practice in 3, 4, 5 years when one of these preventions hits? Think about that. You're going to get your p-tau 217 test alongside your PSA or whatever other test, and well, if it's positive, oh, you're going to go on this medication. Who's going to be writing for that? There's not enough of us, and we're going to have to talk about how do we create the models that make that work. You'll hear more about this a little later. I'm going to leave you with a quote since I'm at the end of my time. Not just that every day more of our life is used up and less of it is left, but this too, if we live longer. Can we be sure our mind will still be up to understanding the world to the contemplation that aims at divine and human knowledge? If our mind starts to wander, we'll still go on breathing, go on eating, imagining things, feeling urges, and so on, but getting the most out of ourselves, calculating where our duty lies, analyzing what we hear and see, deciding whether it's time to call it quits. All things you need a healthy mind for, all of those are gone. So, we need to hurry, not just because we move daily closer to death, but also because our understanding, our grasp of the world may be gone before we get there. Anybody know who said this? Anybody know who that is? Nope, not Aristotle. He also said it more succinctly in another one of his meditations. Read this in his book this past summer. I'm not well read, but I did pick this up when I was at a bookstore. I was like, wow, it's pretty profound. So been thinking about this for millennia, right? So we're not unique, but we do have the opportunity to fix it, right? All right, thank you guys. I guess we're moving on. I don't know. Yeah, go ahead.
So my wife is a marriage and family therapist for many years, and so she has several clients that she's worked with of all ages who show signs of dementia, but they all have trauma histories. So it's almost like they become frozen mentally or even frozen in time. And so when someone is, she was asking in menopause and has trauma history, and they're in their 50s, how do you tease all that out?
Oh boy.
What's causing these?
Yeah, so you just raised like a 3-hour conversation. So that is part of this nuance, right? Is you're trying to look amongst all the